Welcome to this video entitled Tuberculosis Supplemental Chapter. As a way of introduction, let's discuss the epidemiology of TB. Globally 1. In 2015, the World Health Organization, WHO, announced that TB was the leading cause of death from an infectious disease. 2. TB is the most common opportunistic infection in patients with HIV. 1.8 million people died of TB in 2015. B. We will now look at the epidemiology of the United States. 1. In 2015, 9,557 cases of TB were reported. 2. About 500 people die each year of TB. 3. Two-thirds of all reported TB cases are among foreign-born individuals. See individuals who should be tested, according to the Centers for Disease Control and Prevention. 1. Healthcare workers caring for patients with active TB. 2. Individuals in continued contact with someone who has active TB, e.g., family member living in the same household. 3. Individuals from a country where TB is common. 4. Individuals living or working in high-risk settings such as correctional facilities, long-term care facilities, and homeless shelters. And 5. Young individuals, infants, children, adolescents, exposed to adults who are at increased risk of active TB or latent TB infection. D. We will now discuss the transmission of TB. 1. Mycobacterium tuberculosis, abbreviated as MTB, is an airborne disease, spread in particles called droplet nuclei. These droplets may be passed by an infected person through coughing, sneezing, or shouting. 2. The possibility of infection is related to the number of bacilli expelled. 3. Frequent exposure to a person with infection can also lead to infection. E. TB infection control. Centers for Disease Control and Prevention recommends a three-tiered approach to controlling TB, as outlined below. 1. Administrative measures, which entails the following. A. Control plan in place. B. Educating, training healthcare personnel on TB. C. Assigning specific personnel to be in charge of TB infection control. 2. Environmental controls, physical containment of infection through proper ventilation or airflow. And 3. Use of protective respiratory. F. Next we will discuss the diagnosis of TB. 1. Proper history of patient to identify exposure to MTB. 2. Clinical signs of TB include the following. A. Persistent cough. B. Loss of appetite. C. Chest pain. D. Fatigue. E. Night sweats. F. Possible hemoptysis. And G. Other symptoms depend on the location of TB infection. 3. The presence of acid-fast bacilli from sputum microscopy. Many state or hospital laboratories use GeneXpert on smear-positive sputum specimens to identify MTB and rifampin resistance. 4. Positive culture for MTB. Note: a negative culture does not rule out disease. Clinicians must use professional judgment. G. We will now look at goals. The goals of TB treatment are 2. 1. Cure the individual of TB. And 2. To reduce the transmission of TB to other individuals. The American Thoracic Society, Centers for Disease Control and Prevention, Infectious Diseases Society of America guidelines give the three following objectives for anti-TB therapy. 1. Minimize death and disability of the individual patient, i.e., cure the patient. 2. Reduce the transmission of MTB to other individuals. And 3. Prevent MTB drug resistance while the patient is receiving therapy. H. We will now discuss active TB treatment. It is typically divided into a 2-month intensive phase and a 4-month continuation phase. 1. Treatment requires combination chemotherapy. 2. Most patients do not complete therapy within this 6-month period. 3. Treatment may be extended in certain situations such as those listed below. A. Pulmonary TB with a positive 2-month sputum culture. B. Bone and joint involvement. C. Central nervous system (CNS) involvement. D. Patient with HIV not receiving antiretroviral therapy during TB treatment. 4. Susceptibility testing is necessary to determine whether the patient is resistant to any of the first-line medications. We will now discuss the preferred treatment regimens for active TB. Intensive phase. They include the following. 1. Daily dosing is preferred. And 2. Thrice-weekly intermittent dosing may be considered if a patient has a low risk of relapse, like in the following scenarios. 1. MTB is drug susceptible. And 2. Non-cavitary TB and/or smear is negative at start of treatment. B. Patient is HIV negative. 3. Twice-weekly intermittent dosing may be considered if the following conditions are met. A. The patient has completed the initial 2 weeks of daily therapy. B. The patient has a low risk of relapse, like in the following scenarios. 1. MTB is drug susceptible. And 2. Non-cavitary TB and/or smear is negative at start of treatment. C. Patient is HIV negative. 4. Medications used are listed below. A. Isoniazid. B. Rifampin. C. Pyrazinamide. And D. Ethambutol. J. We will now look at preferred treatment regimens for active TB during the continuation phase. 1. A rifampin and isoniazid regimen is continued. 2. Daily or thrice-weekly dosing is recommended. 3. Thrice-weekly dosing is preferred if intermittent dosing is necessary. 4. Isoniazid 900 mg plus rifapentine 600 mg is seldom used and is generally not recommended. This regimen is typically considered only when directly observed therapy greater than once weekly cannot be achieved. Do not use unless the following criteria are met. A patient is HIV negative. B. No cavitation detected on chest radiography. And C. Smear is negative at 8 weeks. Pause the video and carefully scrutinize Table 1 summarizing medications used in the treatment of TB before advancing to the next slide. Next we will discuss HIV tuberculosis co-infection. Let's begin with the epidemiology. Globally. 1. TB is the leading opportunistic infection among patients with HIV. 2. 1.1 million, that is 12%, new TB cases were HIV positive in 2014. 3. Most cases occur in developing countries, primarily sub-Saharan Africa. And 4. Risk of developing active TB is 26 to 31 times greater in individuals with HIV infection than in those without HIV infection. Let's now look at the epidemiology in the United States. 1. 6% of U.S. patients with TB have HIV. 2. Most co-infected cases occur in foreign-born individuals. And 3. U.S. cases have declined since the early 1990s. We will now look at the clinical presentation of TB infection. 1. Patients co-infected with HIV and TB may present differently from patients with TB, who are HIV negative. 2. The level of immunosuppression alters TB progression. Patients with higher CD4 counts, e.g., greater than 350 cells per millimeter cubed, typically present more like their HIV-negative counterparts. 3. In patients with low CD4 cell counts, symptoms may be subclinical. A. Cavitation typically absent. B. Extrapulmonary sites, e.g., lymph nodes, may be more involved. And C. Lower lobe infiltrates are more common. D. Next we will discuss the treatment. 1. The treatment duration is 6 months. 2. Treatment should begin as soon as possible. The START and Temprano trials showed that earlier treatment resulted in reduced AIDS-defining illnesses and death. 3. Immune reconstitution inflammatory syndrome, abbreviated as IRIS, is a concern of patients beginning antiretroviral therapy. Immune reconstitution inflammatory syndrome presents as either a paradoxical worsening of infection, e.g., TB, or an unmasking of a new infection. The symptoms are listed below. 1. Fevers. 2. Respiratory distress. 3. Resumption of cough. And 4. Lymphadenopathy. B. More common in patients with CD4 counts below 50 cells per millimeter cubed. C. Onset is typically within the first 4 to 8 weeks of initiating antiretroviral therapy. D. Both HIV and TB treatments are usually continued unless symptoms are severe. 4. Unique to patients with HIV per terabyte co-infection is the use of several medications, resulting in the following. A. Overlapping drug toxicities. And B. Drug interactions, particularly with the rifamycins, see Table 2. Pause the video and carefully scrutinize Table 2 summarizing the common interactions between antiretrovirals and the rifamycins before advancing to the next slide. We will now progress to latent TB infection. A. Regarding its epidemiology. 1. Some studies indicate that as much as 1/3 of the world's population is infected with TB, i.e., latent TB. 2. 10 to 15 million U.S. individuals are believed to have latent infection. 3. 5% to 10% of individuals with latent TB infection are at risk of progression to active TB. Those at high risk include the following cases. A. Patients with HIV. HIV is the greatest risk factor for progression. B. Older adults. C. Infants and young children. D. Immunocompromised individuals. And E. Injection drug users. B. Next we will discuss diagnostic testing, which entails the use of the following. 1. Tuberculin skin test. A. It involves injection of 0.1 ml of tuberculin purified protein derivative into dermis. B. Its disadvantage is that bacil-calmette-guerin vaccination can cause a false positive. 2. 2 interferon gamma release assays are currently available, namely, a quantiferin TB Gold in tube test and BT spot test. C. Let's now look at the treatment options. They include the following. 1. Isoniazid 300 mg daily for 9 months is preferred treatment for the following scenarios. A. Patients with HIV. B. Children 2 to 11 years of age. The pediatric dose is 10 to 15 mg per kilogram per day. C. Pregnant women, with vitamin B6 and B12 supplementation. We may consider waiting until 2 months postpartum unless 1. The patient is HIV positive, and 2. Patient had a recent contact. D. Breastfeeding is not a contraindication. E. Isoniazid 300 mg daily for 6 months is more cost-effective. However, it is less effective at preventing active disease than the 6-month option. 2. Isoniazid 900 mg twice weekly for 9 months is preferred treatment for a pregnant women. Should be treated with vitamin B6 and B12 supplementation. B. Directly observed therapy should be used. C. Isoniazid 900 mg twice weekly for 6 months is a more cost-effective option. However, it is less effective at preventing active disease than the 6-month option. D. The recommended pediatric dose is 20 to 40 mg per kilogram twice weekly for 9 months. 3. Isoniazid 900 mg once weekly in combination with rifapentine 900 mg once weekly. A. Is a treatment option for individuals older than 12 years. B. Currently, it must be given directly observed therapy. C. It is not recommended for the following cases. 1. Individuals younger than 2 years. 2. Patients with HIV, AIDS. 3. Women who are pregnant, or expecting to become pregnant during treatment. And 4. Individuals believed to be infected with isoniazid or rifampin-resistant MTB. 4. Rifampin 600 mg daily for 4 months. A alternative for patients who cannot tolerate isoniazid. B. The recommended pediatric dose is 10 to 20 mg per kilogram per day for 6 months. 5. Rifampin and pyrazinamide for 2 months is not recommended because of an increased risk of hepatotoxicity and death. D. Note on treatment. Active TB must be ruled out before latent TB infection can be treated. We will now progress to individual medications for active tuberculosis. A. Let's begin with isoniazid. 1. Regarding its place in therapy, it is a first-line agent. Isoniazid and rifampin are the 2 most important agents in treating active TB. 2. Next we will discuss its mechanism of action. A. Isoniazid inhibits mycolic acid synthesis. B. It is most effective during the first few days of treatment because of its potent early bactericidal activity, abbreviated as EBA. During this time, the largest proportion of MTB are rapidly dividing. Early bactericidal activity refers to a drug's ability to rapidly reduce the number of bacteria. Typically, early bactericidal activity refers to the first 2 to 5 days of treatment, but can refer to a period of up to 2 weeks. Extended early bactericidal activity. CC marks is the pharmacokinetic parameter most associated with efficacy. 3. We will now look at the dose of isoniazid. A. The daily dose is 300 mg. Expected C marks is 3 to 5 micrograms per milliliter 2 hours post-dose. B. The intermittent dosing is 900 mg, 2 or 3 times weekly. Expected C marks is 9 to 15 micrograms per milliliter 2 hours post-dose. C. Higher doses of 450 to 600 mg may be needed in patients with low isoniazid concentrations, such as fast acetylators, or in patients with TB experiencing malabsorption. D. Food reduces the oral absorption of isoniazid, and the agent should be administered on an empty stomach. 4. We will now discuss the adverse effects of isoniazid, which are listed below. A. Hepatotoxicity. Subclinical hepatitis occurs in as many as 10% of patients. 1. Anorexia, weight loss, GI upset may occur. 2. Aspartate aminotransferase and alanine aminotransferase should be monitored. 3. Slow acetylators may be at higher risk of hepatotoxicity. B. Peripheral neuropathy. 1. To avoid peripheral neuropathy, administer 50 mg of pyridoxine. 2. The risk of peripheral neuropathy is higher in patients with diabetes mellitus, patients with HIV, pregnant women, and patients who consume large amounts of alcohol. 5. The enzyme that is responsible for its metabolism is acetylation by N-acetyltransferase. Among the rapid acetylators, its half-life is 1 to 2 hours. There may be at greater risk of treatment failure among them. B. Among slow acetylator half-life is 3 to 4 hours. 6. Its drug interactions are listed below. A. Isoniazid can inhibit CYP2E1, CYP2C19, and CYP3A. B. Isoniazid can induce CYP2E1. See examples of medications that may be affected by co-administration with isoniazid include warfarin, phenytoin, and carbamazepine. B. Next we will look at rifampin. 1. Regarding its mechanism of action, A. It inhibits the beta subunit of MTB's RNA polymerase, preventing transcription. B. It kills actively dividing bacilli as well as dormant bacilli. C marks and AUC are both associated with efficacy. C marks may be more associated with preventing resistance and AUC with bactericidal activity. 2. Next we will discuss the dose of rifampin. A. The recommended adult and pediatric dose 10 to 20 mg per kilogram. Up to a 600 mg oral dose is typical starting daily and intermittent dose 1. Some argue that 600 mg is too low. 2. Administer it 1 hour before or 2 hours after a meal. B. Its expected C marks is 8 to 24 micrograms per milliliter 2 hours post-dose. 3. Its adverse effects are listed below. A. Hepatotoxicity. 1. Minor risk of hepatotoxicity, which is additive to isoniazid. 2. Risk factors include the following: alcohol, advanced age, diabetes mellitus, and concomitant hepatotoxic medications. B. Flu-like syndrome. 1. It occurs with large, that is 900 to 1,800 mg, intermittent doses but seldom with daily doses. 2. It usually occurs after months of treatment. See orange fluid discoloration. 1. This is not an adverse effect per se. 2. Sweat, tears, and urine may be red, orange. Not harmful, but patients should be made aware. B. Next we will look at rifampin. 1. Regarding its mechanism of action, A. It inhibits the beta subunit of MTB's RNA polymerase, preventing transcription. B. It kills actively dividing bacilli as well as dormant bacilli. C marks and AUC are both associated with efficacy. C marks may be more associated with preventing resistance and AUC with bactericidal activity. 2. Next we will discuss the dose of rifampin. A. The recommended adult and pediatric dose 10 to 20 mg per kilogram. Up to a 600 mg oral dose is typical starting daily and intermittent dose 1. Some argue that 600 mg is too low. 2. Administer it 1 hour before or 2 hours after a meal. B. Its expected C marks is 8 to 24 micrograms per milliliter 2 hours post-dose. 3. Its adverse effects are listed below. A. Hepatotoxicity. 1. Minor risk of hepatotoxicity, which is additive to isoniazid. 2. Risk factors include the following: alcohol, advanced age, diabetes mellitus, and concomitant hepatotoxic medications. B. Flu-like syndrome. 1. It occurs with large, that is 900 to 1,800 mg, intermittent doses but seldom with daily doses. 2. It usually occurs after months of treatment. See orange fluid discoloration. 1. This is not an adverse effect per se. 2. Sweat, tears, and urine may be red, orange. Not harmful, but patients should be made aware. See next we will discuss rifabutin. 1. Regarding its place in therapy, it is recommended as a substitute for rifampin because of rifampin's potent enzyme induction. Rifabutin induces enzymes about 40% as much as rifampin. 2. Regarding its mechanism of action, it inhibits the beta subunit of MTB's RNA polymerase. 3. Next we will look at its dose. A 300 mg dose is the typical starting daily and intermittent dose. B. A 450 mg dose is recommended with CYP3A inducers. C. A 150 mg dose is recommended with CYP3A inhibitors. D. The expected C max is 0.3 to 0.9 micrograms per milliliter 3 to 4 hours post-dose. E. Food has little effect on absorption. 4. Next we will look at its adverse effects. They are concentration-related. They are listed below. A. Anterior uveitis. B. Arthralgias. And C. Leukopenia. 5. And now we will discuss the metabolism of rifabutin. A. It undergoes extensive intestinal and hepatic metabolism. B. It is a CYP3A substrate. 6. Let's now look at its drug interactions. A. It has most of the same drug interactions as rifampin, though not to the same extent, about 40% of that with rifampin. B. It is a CYP3A4 substrate. Thus, bidirectional interactions are possible and must be considered. See Table 3 for drug interactions with HIV antiretrovirals. D. We will now progress to rifampin. 1. Regarding its place in therapy, it is rarely used in the continuation phase of active TB treatment. B. It may be used in the treatment of latent TB infection. 2. Regarding its mechanism of action, it inhibits the beta subunit of MTB's RNA polymerase. 3. We will now discuss the dose of rifampin. A. It is dosed at 600 mg once weekly for continuation phase. B. It is dosed at 900 mg once weekly with 900 mg of isoniazid once weekly for 12 weeks for latent TB infection. Seafood increases AUC by 30% to 80%. 4. Next we will look at the adverse effects of rifampin. They are listed below. A. Hepatotoxicity. B. Flu-like syndrome. And C. Discoloration of bodily fluids. 5. Next we will discuss the metabolism of rifampin. It is hydrolyzed by esterases to its less active metabolite, 25-decacetyl rifampin. 6. Its drug interactions are similar to those of rifampin. Rifampin's induction capabilities are as potent, or almost as potent, as those of rifampin, so it offers no advantages over rifampin in avoiding drug interactions. E. Next we will discuss pyrazinamide. 1. Regarding place in therapy, it is a first-line agent used during intensive phase. B. It shortens the therapy duration from 9 months to 6 months. 2. We will now look at its mechanism of action. A. It is not fully known. B. It is a prodrug that is activated by the enzyme pyrazinamidase within MTB. 3. Its dose is as listed below. A. 25 mg per kilogram daily. B. 50 mg per kilogram twice weekly. C. 30 to 40 mg per kilogram daily for pediatric patients. D. If creatinine clearance is less than 30 ml per minute per 1.73 meters squared, consider a 25 to 35 mg per kilogram per dose thrice weekly. 4. Its adverse effects are listed below. A. Arthralgias. B. GI upset. And C. Hepatotoxicity, increased risk with higher doses. 5. Regarding its metabolism, it is oxidized to 5-hydroxypyrazinoic acid, metabolized in liver, but metabolites can accumulate in patients with severe renal dysfunction. 6. Regarding its drug interactions, it has no significant drug interactions. F. Let's now look at ethambutol. 1. Regarding its place in therapy, it is a first-line agent used during intensive phase to protect rifampin from isoniazid resistance. Ethambutol may be discontinued once data return that MTB is susceptible to isoniazid. 2. Regarding its mechanism of action, it inhibits arabinogalactan, a part of MTB's cell wall synthesis. 3. Its dose is listed below. A. 15 to 25 mg per kilogram daily. B. 50 mg per kilogram twice weekly. C. The pediatric dose is 25 mg per kilogram per dose daily. D. Its C marks is 2 to 6 micrograms per milliliter at 2 to 3 hours. E. Food does not affect absorption. However, antacids should be avoided within 2 hours of dosing. 4. Its adverse effects include optic neuritis. A. It is a concentration-dependent toxicity. B. It is less common in patients with normal renal function. C. It is less common in patients taking doses lower than 30 mg per kilogram per day. D. Routine testing for visual acuity using Snellen charts should be done. E. Routine testing for red, green color discrimination using Ishihara color plates should be done. F. If optic neuritis is recognized promptly, vision usually returns to baseline. 5. We will now discuss its metabolism. A. It is cleared renally and hepatically. Up to 50% is excreted unchanged in the urine. B. Dose adjustment is necessary in patients with renal dysfunction. 6. Regarding its drug interactions, as with pyrazinamide, there are no significant drug interactions. We will now progress to multi-drug resistant tuberculosis. A. As a way of definition, it is MTB that is resistant to isoniazid and rifampin. Primary cause is inadequate treatment of drug-susceptible TB. B. Regarding its epidemiology, 2015 global estimates. 1. Around 480,000 individuals infected globally. 2. It accounts for 3.3% of new cases. 3. Around 250,000 people died of multi-drug resistant tuberculosis. C. Regarding the treatment of multi-drug resistant tuberculosis. 1. At least 5 effective medications should be used in treating multi-drug resistant tuberculosis. This is a standard regimen. A. Pyrazinamide should be included, if isolate is susceptible. B. The intensive phase is recommended for 8 months. C. Continuation phase is 12 months of at least 3 or 4 effective medications. D. Treatment may be extended in either phase, depending on clinical response. E. Treatment can vary depending on factors such as extent of disease, patient tolerance, and patient comorbidities. F. A short course regimen of 12 months or less is a treatment option recommended by the WHO in patients not previously treated with second-line TB medications whose MTB isolate is susceptible to the medications being used in the treatment regimen. 2. According to the 2016 guidelines, the WHO groups them on the basis of evidence of efficacy and safety. A. Group A consists of a fluoroquinolone, E. G1, levofloxacin, or 2. Moxifloxacin. B. Group B consists of aminoglycosides and capreomycin. E. G1. Amikacin. 2. Capreomycin. 3. Kanamycin. Or 4. Streptomycin. C. Group C consists of other core second-line agents, e.g. 1. Ethionamide or prothonamide. 2. Cycloserine or tirizidine. 3. Linezolid. Or 4. Clofazimine. D. Group D consists of add-on agents as listed below. 1. D1. Pyrazinamide. 2. D1. Ethambutol. 3. D1. High-dose isoniazid. 4. D2. Bedaquiline. 5. D2. Delamanid. 6. D3. Para-aminosalicylic acid. 7. D3. Imipenem C-lastin. 8. D3. Meropenem. And 9. D3. Amoxicillin, clavulanate. 3. Patients should receive the following. A. Pyrazinamide B1 medication from Group A, C1 medication from Group B, and D2 medications from Group C4. Note that macrolides are no longer recommended in the treatment of multi-drug resistant tuberculosis. 5. Note: medications in groups A and C are grouped by order of preference. 6. Note: if patients cannot be treated with the minimum number of effective TB medications as listed earlier, an agent from Group D2 and/or agents from Group D the third of may be added to make a total of 5 effective medications. D. Next we will look at individual medications used for treatment of multi-drug resistant tuberculosis. 1. Moxifloxacin. A. Regarding its place in therapy, 1. It is one of the first medications selected for multi-drug resistant tuberculosis because of its desirable pharmacokinetic, pharmacodynamic properties. 2. Moxifloxacin's minimum inhibitory concentration against MTB is 0.125 to 0.5 micrograms per milliliter. B. Regarding its mechanism of action, it inhibits DNA gyrase. C. Regarding its dose, 400 mg is the typical starting dose. D. Regarding its metabolism, 1. It is primarily metabolized by phase II enzymes. And 2. No renal dose adjustment necessary. E. Regarding its drug interactions, 1. Rifampin decreases moxifloxacin's AUC by 27%. A 600 mg moxifloxacin dose may be necessary to overcome this reduction. 2. Avoid its use with drugs containing di- or trivalent cations. 2. Levofloxacin A. Regarding its place in therapy, 1. It is one of the first-line medications selected for multi-drug resistant tuberculosis because of its desirable pharmacokinetic, pharmacodynamic properties. B. Regarding its mechanism of action, it inhibits DNA gyrase. C. Regarding its dose, 1. It is dosed at 750 to 1000 mg daily. That is about 10 mg per kilogram. 2. Food causes only a modest reduction in C marks and no overall change in AUC. D. Regarding its metabolism, it is eliminated renally, so dose adjustment is necessary in renal dysfunction. E. Regarding its drug interactions, avoid with drugs containing di- or trivalent cations. 3. Next we will look at aminoglycosides, e.g. amikacin, kanamycin, and streptomycin, and capreomycin. A. Regarding their mechanism of action, they inhibit protein synthesis. B. Their recommended dose is as listed below. 1. They are dosed at 15 to 20 mg per kilogram. 2. Their C marks is 35 to 45 micrograms per milliliter with daily dosing. 3. Their C marks is 65 to 80 micrograms per milliliter with thrice weekly dosing. See their adverse effects are listed below. 1. Nephrotoxicity. 2. Ototoxicity. 3. Peripheral neuropathy. And 4. Rash. D. Regarding their metabolism, they are eliminated by glomerular filtration. E. Regarding drug interactions, interactions are mainly limited to medications that can reduce a patient's renal function. Next we will discuss clofazimine. A. Its mechanism of action is not fully elucidated. It may prevent replication by selectively binding mycobacterial DNA at the guanine base, or maybe because of the production of reactive oxygen species. B. We will now look at the dose of clofazimine. 1. It is dosed at 50 to 200 mg once daily. 2. Its Cmax is 0.5 to 2 micrograms per milliliter. Its Tmax is variable, ranging from 2 to 12 hours post-dose. See its adverse effects are listed below. 1. Skin discoloration is the most common adverse effect, a bronze discoloration of body tissues, which typically manifests within the first few weeks after initial treatment, but may last months to more than a year after discontinuation. Dry skin is also common. 2. G. I intolerance. D. Its metabolism is primarily hepatic, though not fully understood. E. Regarding its drug interactions, there are no significant drug interactions. 5. Next we will look at cycloserine. A. Regarding its mechanism of action, it disrupts the incorporation of D-alanine into peptidoglycan during cell wall synthesis. B. Its dose is as listed below. 1. It is dosed at 10 to 20 mg per kilogram twice daily, typically 250 to 500 mg. 2. Pediatric dose typically 10 to 20 mg per kilogram per day in 2 divided doses. 3. Cmax of 20 to 35 micrograms per milliliter 1 to 2 hours post-dose. 4. Dosage adjustment necessary in patients with renal dysfunction, with target concentrations less than 30 micrograms per milliliter, not recommended in patients with a creatinine clearance of less than 50 milliliters per minute per 1.73 meters squared. See its adverse effects are listed below. 1. The most common CNS adverse effects include anxiety, confusion, depression, dizziness, difficulty concentrating, drowsiness, lethargy, hyperexcitability, paresthesias, seizures, tremor, and vertigo. 2. CNS toxicity may be greater at higher concentrations, greater than 35 micrograms per ml, and concentrations should be maintained below 30 micrograms per milliliter to reduce the risk of adverse effects. D. Its metabolism is primarily renal, with minimal hepatic metabolism. Do not use cycloserine if creatinine clearance is 50 milliliters per minute per 1.73 meters squared. E. Regarding its drug interactions, it has no significant drug interactions, though an increased risk of neurological symptoms may occur with isoniazid or the fluoroquinolones. 6. Next we will discuss ethionamide. A. Let's begin with its mechanism of action. 1. It acts by inhibition of mycolic acid synthesis. 2. Its cross-resistance with isoniazid is possible. B. Its dose is listed below. 1. It is dosed at 250 to 500 mg twice daily is typical. 2. The pediatric dose is 15 to 20 mg per kilogram per day divided twice daily. 3. Its Cmax is 1.5 to 3.0 micrograms per milliliter 2 hours post-dose. See its adverse effects are listed below. 1. G. I adverse effects can be severe. We can reduce them by splitting the dose initially. or starting with lower doses and increasing gradually. 2. Other, less common adverse effects are listed below. A. Hepatotoxicity. B. Visual disturbances. And C. Goiter. D. It is metabolized by sulfoxidation, desulfurization, and deamination, followed by methylation. 2. 250 to 500 mg orally daily recommended in patients with a creatinine clearance less than 30 ml per minute per 1.73 meters squared. E. Regarding its drug interactions, it has no significant drug interactions. 7. Let's now progress to linezolid. A. Regarding its mechanism of action, it binds to 23's rRNA, inhibiting protein synthesis. B. It is dosed at 600 mg daily. C. Its adverse effects are listed below. 1. Diarrhea and nausea. 2. Headache. 3. Anemia. 4. Thrombocytopenia. 5. Lactic acidosis. 6. Peripheral neuropathy. And 7. Optic neuropathy. D. Its metabolism is primarily via oxidation. E. Regarding its drug interactions, it is contraindicated with monoamine oxidase inhibitors. 8. Let's now discuss para-aminosalicylic acid. A. Its mechanism of action is unknown. It has activity against folic acid pathway. B. Its dose is listed below. 1. 4 grams 3 times daily. A twice-daily schedule has been used as an alternative. 2. Pediatric dose is 50 mg per kilogram 3 times daily, up to 12 grams per day. 3. Granules best absorbed with food. 4. Its Cmax is 15 to 20 micrograms per milliliter 4 to 6 hours post-dose for sustained release granules. C. Its adverse effects are listed below. 1. G. I upset is the most common. Newer aminosalicylic acid, PAR, granules are better than older dosage forms. Diarrhea is still a common adverse effect, but this usually improves within the first 2 weeks of administration. 2. Hypothyroidism. And 3. Steatorrhea. D. Regarding its metabolism, it is metabolized in the GI tract and liver to inactive metabolites. E. Regarding its drug interactions, it has no significant drug interactions. F. Notes. It is available as granules. Empty granules may pass through system and appear in the patient's stool. 9. Next we will discuss bedaquiline and delamanid. A. Let's begin with bedaquiline. According to the Centers for Disease Control and Prevention, bedaquiline may be used as part of combination therapy for pulmonary TB, when an effective treatment regimen cannot otherwise be provided. Currently limited by cost and safety concerns, delamanid was approved by European Medicines Agency, but not in the United States at this time. E. Next we will briefly discuss therapeutic drug monitoring. 1. The measuring of serum drug concentrations to individualize drug therapy in conjunction with other relevant patient factors, e.g., clinical signs and symptoms, laboratory tests. 2. It may be used to assess patient adherence, maximize efficacy, or minimize adverse events. 3. For the first and second line TB drugs, 2 concentration time points can be measured to help individualize therapy: a 2-hour sample and 3 hours for rifabutin, and a 6-hour sample. The 2-hour sample captures the Cmax. See Table 3. 4. A 6-hour sample is used to determine malabsorption or delayed absorption. A. Regarding malabsorption, both 2 and 6-hour concentrations are below the expected range. An increased dose may be necessary. B. Regarding delayed absorption, the 2-hour concentration is below the expected range. but the 6-hour concentration is within range and no dose adjustment necessary. Pause the video and carefully scrutinize Table 3 summarizing targeted concentrations for TDM of TB agents before advancing to the next slide. Thank you.